This week on the Backtable Podcast.
I think if you approach the different treatments, TACE or radioembolization, in that manner, you need to have something that helps you overcome those hydrostatic forces. You know, the fact that, you know, a lot of these patients are on VEGF or EGFR inhibition, and that's going to change that microenvironment as well. So if you're not preparing yourself to deal with that, then you're going to fall on your face.
Hello and welcome to the Backtable Podcast. Backtable is your resource to connect with your IR colleagues and learn tips, techniques, and the ins and outs of the devices in your cabinets. You can find all previous episodes of the podcast and more on our free iTunes app. This is Mike Barraza returning as your host. Today's podcast is brought to you by Surefire Medical. Surefire has the only expandable tip catheter to help physicians maintain blood flow while reducing reflux during chemoembolization and radioembolization. The Surefire infusion system helps interventional radiologists deliver therapy deeper into tumors while protecting healthy tissues. Learn more at surefiremedical.com. Today's episode is the second in a two-part series exploring the optimization of tumor uptake on therapeutic embolic materials delivered in transarterial interventions for HCC. In part one of this series, Dr. Charlie Nutting and Ninesh Parikh debated the merits of pressure-directed infusion to improve selected delivery of radioembolics and minimize non-target embolization during Y90 radioembolization. Today, we're furthering that discussion to focus on maximization of tumor uptake and chemoembolization. I'm honored to be joined today by Drs. Justin Lee and Terence Gade. Thank you both for being a part of this. If you don't mind, I'd like to begin by asking you each to tell us a little bit about yourselves and your practice, as well as the role chemoembolization currently plays within it. Starting with you, Justin.
Okay, well, my name's Justin Lee. I'm a interventional radiologist in Sarasota, Florida. I actually was a direct pathway resident, the first one, believe it or not, at Georgetown University. And after I finished my training there, I stayed on as a faculty for 4 years, and then kind of got burned out on academics and decided to move my family someplace a little bit more desirable to live. So we moved to Sarasota, Florida, which is a community on the west coast of Florida. It's a big hospital, 820-bed hospital that really had no interventional radiology going on when I accepted the job. And coming up in May, it'll be 5 years I've been here. We've really righted the ship, and we have a pretty robust IO program, doing a lot of radioembolization, a lot of TACE, a lot of ablation. And because of where we're located, which is we're about an hour and a half south of Tampa, we're about an hour and a half north of Fort Myers, we have a huge catchment area. So we've really been able to bring sort of advanced IO procedures to the community and keep people here in the community rather than having them travel to Miami or Moffett and Tampa. That's been really rewarding. And in addition to that, we've just advanced a couple research trials where I'm the PI, or the local PI, and one of them is the Surefire Registry for HCC. We're part of the resin registry, and so we've incorporated things like the Surefire catheter into those trials because we believe that there is a utility in the catheter. So
next we have Dr. Terence Gade, and I should probably mention that I know his story because I trained under him, finished up about 6 months ago. But for the sake of our listeners, Terence, tell us about chemoembolization at Penn and what you're doing.
Like you just mentioned, my name is Terence Gade. I'm an assistant professor and attending interventional radiologist at the Hospital University of Pennsylvania. I'm assistant professor of cancer biology and radiology, and I'm a co-founder and co-director of the Penn Image Guided Interventions Lab. And my practice is a little bit different from most in the sense that I'm predominantly in the lab. So I'm about 30% clinical and 70% research. So my perspectives are a little bit colored by what my practice looks like. So you mentioned specifically chemoembolization at Penn, and I think we're fortunate to have one of the real pioneers in interventional oncology at Penn, Michael Solon, and you and I both trained under him, and I think our approach is definitely influenced by his thoughts and considerations. And so we focus on conventional TACE using Lipiodol as a drug delivery agent, followed by an embosphere as the embolic. In addition to conventional TACE, which is predominantly what's done at HUP, we also perform Debtaste, which we do predominantly at the VA. So I do get the opportunity to sort of contrast and compare those different approaches.
And Terence, you've really run with a lot of the stuff that Michael Sullivan has started. I mean, you were the first ever radiologist to receive the NIH Director's Early Independence Award. And that grant was specifically to investigate imaging of metabolic changes in cells after chemoembolization. Is that correct?
Yes, that's right. So we were fortunate enough to get some support from the NIH to start to think about some of the biology that underlies the cellular response to TACE, how we can leverage that response to improve therapy. And that sort of emphasized the stress responses that these cells mobilize in the ischemic environment and how that generates vulnerabilities that are not necessarily sensitive to mutations. As we know, cancer is a genetic disease, and there are a number of mutations that underlie cancer. And cancer cells can further mutate those pathways, but there are a set of pathways that are not often mutated because they are so essential for these cells to survive. And we've been looking at how the ischemia induced by different embolic methodologies can generate these dependencies and how we can go about targeting them. But to target them, obviously, we first have to know that these cell populations exist, these populations that are dependent on these stress response pathways. And we focused on developing a hyperpolarized metabolic imaging approach to be able to start to see cell populations that we can't visualize using conventional imaging approaches.
Now, is the Piggy Lab following with this as well, or is that something separate?
No, this is all part of the Piggy Lab. So the Piggy Lab was founded by Greg Nadolsky and Stephen Hunt and I, and as residents actually, and then as we developed into fellowship and stayed on as attendings, the Piggy Lab is sort of it's a team science lab where we have multiple investigators with shared interests, and so it encompasses a broad range of different projects. All of them focus on the tumor microenvironment and how that can be modulated through image-guided interventions.
Before we get into this a bit more, I do want to bring up one point. There's been a lot of buzz about some of the more recent data comparing chemoembolization to radioembolization for HCC. Do either of you anticipate any changes to your approach in the coming years?
I'm not really compelled by single institution data that suggests that Y90 is superior to TACE, particularly for a disease that falls in the spectrum for TACE.
Okay.
So, in my practice, if, we're not a transplant center. So if I have a small lesion, for me, that if it falls into my realm and that patient's not going to be a transplant candidate, and that happens often because we've got an octogenarian population here, and they might not be a great surgical candidate. They're out of Milan for transplant. If I have a small lesion, I'm going to probably do TACE ablation if that person's not going to be resected. So we pretty much follow the BCLC, and we don't really amend it. So if they're BCLC-A and they've got a small lesion or one lesion or maybe a few lesions, but they're all less than 5 centimeters or even less than 3 centimeters, then I'm going to TACE ablate that before I would apply Y90. For me, radioembolization is a tool for metastatic disease. And really in my practice at Georgetown, that was like the gateway for us to get into metastatic disease. And by that, I mean colorectal, pancreas. I mean, we apply it just about anything that we think is radiosensitive or the patient would do better with a wider scope of embolization using a different model rather than, vessel occlusion and drug, then we would apply radioembolization. So for me, if somebody has portal vein invasion, if they have HCC with portal vein invasion, or their disease is behaving more as if they were a patient who had metastatic disease, and by that I mean bilobar disease, large infiltrative lesions, vascular invasion, that is for me a radioembolization patient. Beyond that, if I travel around the country and we obviously are doing a lot of radioembolization for HCC, and I see patients treating, IRs treating 5 centimeter unilobar lesions with Y90. And I just think that's kind of I think you're kind of applying something that costs more. It's got a lot more nuances to it. and without a real demonstrable survival benefit, except potentially for cases of portal vein invasion. I think that you're walking down a road of healthcare cost and risking, particularly if you're in the community, you're risking marginalizing your medical oncologist too, because what's sneaky around the corner are the PD-1 inhibitors, which are being widely applied for better or for worse. And I think that if you stray from guidelines just because your institution is has a lot of experience with radioembolization, you're gonna get all of us in trouble. But that's my opinion.
No, I'm a huge fan of the TACE ablation approach. I think you bring up a very important point when you mention the community aspects and specifically the word marginalization. It bears reminding that we just have so much more history with TACE as a procedure, and it's much more accessible in smaller communities, much smaller than Sarasota even. I mean, you're not going to find Y90 in 200 miles from where you are outside of a larger city.
Well, I think you'd be shocked, actually. I just helped to open an account in Inverness, Florida, which is kind of in the middle of nowhere, and it took me 2.5 hours to drive there. And the thing is that for me, I feel like Y90 is what I will agree with Northwestern. Y90 is a very well tolerated procedure, and clearly they've shown that TACE and Y90, TACE has more side effects. Some of the initial articles though were all CAM TACE, which I'm really interested to hear, from Terence in terms of they're still using Lipiodol. I would say that most people are not using Lipiodol, and for me, Debtaste, I don't know. I send people home oftentimes on the same day as the Debtaste. So the point you bring up about accessibility, I'd like to see Y90 more accessible in the community, but it is true. I mean, we did a little analysis. It's like 25 to 30% of our population does not have Medicare and they're on Medicaid. Well, I already know before I see that patient that they're not a Y90 candidate. Whether I want them to be or not, I've got to be a little bit creative with how I'm going to treat those patients. And I can get somebody scheduled for a TACE the next day pretty much. I mean, granted bead loading and that type of thing. Versus a Y90, you can wait sometimes a long time still in, that sort of predetermination area. And if you're not fast in the community, your oncologist is going to move along. And I think that's another point that people don't really think about. And when I was in academics, I was in that role where, we were getting people from the community. A lot of them were failures, or they just didn't, people didn't want to treat them in the community because HCC doesn't really have a whole lot of infusional therapies. And yeah, it's okay. Then you can start applying Y90. But when you start to get out into what I don't want to call it the real world and be a jerk or anything, but, in the community, you're not going to have that luxury. You're not going to be able to apply a therapy that the dose alone is $16,000. And, you've got to map them once and then treat them again. And, I'm getting long-winded here, but even when you look at Northwestern, they were doing mapping and treating on the same day, and their own institution, told them to stop that because from a standpoint of your own hospital, that's just not financially feasible for them. They want you to treat them on separate days. And when you look at the nitty-gritty of the program, I think TACE is it's easy, it works, it's effective, patients do well from it, and it's been tried and true since the 90s.
Right. Terence, anything to add there?
Yeah, I would echo a lot of the things that Justin mentioned. I would say that we're clearly, especially with the work that's coming out of Northwestern and the Premier trial, making significant strides with respect to characterizing the variety of different endovascular local regional therapies we can apply. But we obviously, as Justin's mentioning, we have a lot of important progress to make. And specifically, I think we really need to use all the information at our disposal. And this is sort of how I think about it, and I think a lot of my colleagues think about it, and not assume that every tumor is alike or every HCC is alike, and really consider the biology of the tumor and what data we have from our imaging to sort of influence that, because our ultimate goal and I think, with the Cancer Moonshot and a lot of these initiatives going on, is to apply a precision medicine approach. And while, that can mean a lot of different things to different people, I think we do have tools to generate a precision medicine approach in this regard, looking at the vascularity of the tumor and things of that nature. So, we tend to choose therapies on a patient-by-patient basis, factoring in, all the things that Justin mentioned, clinical considerations, in particular liver function. Like I mentioned, the biology of the tumor in terms of vascularity. And where available, and this is becoming increasingly common, is data regarding tissue biopsy, what we know on a molecular level about the tumor itself, and what that could mean for its susceptibility to radiation versus in a more ischemic-driven technology.
Okay. Now, Terence, because you have experience with both conventional TACE and Debtaste, very commonly, this gives us some interesting perspective on this. Could you tell us a bit more about your experience with both, the benefits, advantages, disadvantages, and if you have a preference?
Sure. I agree with Justin. I think the side effect profile for DEBS is far better, and patients tend to do, better afterwards. How much it's a hard thing to say, I think. But I from a biological standpoint, I do believe that, and I think, Karen Brown's work underscores this, that the ultimate therapeutic effect comes from the ischemia we're inducing. So I think that I'm a big believer in the embolization component, and I'm less of a believer in the chemotherapeutic. So my concern with DEBS tends to be that that's more focused on drug delivery. It's about getting more docs or what have you to the tumor. And I think that in terms of what data we do have, those chemotherapeutics are probably not the best choice. The ones we're using are probably not the correct drugs. And if we're talking about inducing vulnerabilities, if we embolize the tumor and we block off the vasculature and we induce ischemia, those cells are now fundamentally different from the cells that were growing without the embolization. And the cells without the embolization tend to be proliferating, as we see on scans. We see tumors grow. But after embolization, they can sort of hang out there without growing. And that tells us a lot about the cell status. So in that circumstance, you have cells that aren't cycling anymore, but we're using an agent that's meant to potentiate the ischemia. And using an agent that targets proliferating cells is probably not going to potentiate that ischemia a whole lot. And again, I think that JCO article from Karen Brown underscores that concept. So, while I do, prefer the side effect profile for Debtaste over conventional TACE, I think that ultimately the biology we're targeting is better served through conventional TACE approach than it is through Debtaste. And that sort of, I would caveat that by saying that I think we really need to start thinking, and there's a lot of research being done in this area, but start thinking about which drugs we're combining to potentiate the ischemia. And there's a lot of progress been made in that area. And I think we as interventionalists really need to start thinking about that biology and integrating some of those therapeutics into our practice rather than, sort of taking what's always been administered, really, when the decision was made to start using those drugs, cisplatin, mitomycin, and doxorubicin, there wasn't any real reason. It wasn't that HCCs are susceptible to those drugs, because they can be, HCCs are among the most chemo-resistant cells that we know of in cancer. So I think we need to do a little better job of thinking rationally about the therapeutics we're using and integrating our science.
Now, Justin, a question I have for you, because most of my experience is limited to conventional TACE. Comparing Debtaste to Y90, we're obviously dealing with a difference in the relative embolic effect of the treatment material. For Y90, you're generally committed to delivering a pre-calculated dose, which is generally attainable due to the comparatively low embolic load. But for chemoembolization, it at least for Lepidol, for conventional TACE, the goal is just to deliver as much as you can safely before reaching stasis. So, with Debtaste, with conventional TACE, I think we've all been surprised by how much or little it takes to get to stasis in certain patients. Like, what is your goal mainly for Debtaste? Like, how do you know when you've gotten there? And is it really about how much of a value you give?
Well, First, I'd actually like to, so for me, the way I was trained was exactly the way you guys were trained. I mean, TACE was what it was. Debtaste didn't come around until I was actually practicing. And the interesting thing about it was that, we saw the drugs one by one go away and lack of availability. And I have to plug one of my attendings at the time. His name is Karun Sharma. He was part-time at Georgetown, part-time at the NIH. He was probably the first guy to use drug-eluting beads. And at the time, what we had was 300 or 500 micron size beads. And when I first became an attending, I was like, I don't see the real reason to use this. This was before Precision 5. And I persisted trying to do essentially TACE with doxorubicin. But at that time, too, doxorubicin was no longer in a powdered form. It was liquid. So you would get, instead of having this concentrated red toxic looking mix, you would get this sort of diluted looking mix. And I actually had treatment failures. And that's kind of what pushed me over the edge into Debtaste. And, things have obviously changed too. We had a Lipiodol shortage, which also kind of pushed us to Debtaste. And so I wonder a little bit, outside of, Penn, if a lot of people just sort of did Debtaste because they had to. It was out of necessity. It wasn't necessarily out of, that we thought it was superior. I mean, one of the things that I look at when I trained, I mean, one of our endpoints for TACE when using Lipiodol was that we would see sort of portal venous staining. And you don't get that when you're using beads. And everybody assumes also, from a Y90 standpoint, because the Y90 beads are so much smaller, 20 to 60 microns in size, that smaller was better. But that's, Dave Liu has a great talk on that. The smaller beads, the M1 beads and the ones that are, under 100 microns, well, they drop their drug really quickly. And, one of the funniest things happened is sort of a little anecdote. But when I introduced Debtaste down here, Debtaste, I said, we use doxorubicin, and they hadn't really been doing it. And they're like, well, why would you use doxorubicin? We know that doesn't work on really anything except breast cancer, really. So it was kind of funny, and I don't have a response for that. It's an old, crappy cytotoxic drug that has a lot of side effects. And here we say, well, we're going to, this is cutting edge. I'm going to introduce this to Sarasota. We're going to put doxorubicin on a bead, and I'm going to administer it via the artery. And, I think that's sometimes a little hard for a community oncologist to swallow. So getting back to your question, again, I think for me, I agree, and I'm not a bench guy, but I agree that for me, embolization is more important. And if you really look at Precision 5, which I know is old at this point, but, after they put in, Debdox, they went to stasis. So that's probably my endpoint. If I don't achieve stasis, I feel like I haven't done my job. So I'll bland embo after that. And, and then again, I'm really big on ablating the lesions after if I can. And, the rationale for that for me is, I have to live in the world of sort of competitive medicine, and we do have tumor boards and whatnot, but, I need to offer as close to a surgical resection as possible. So I, and then to take it one step further, which again, this is more in Terence's world, but I believe a little bit in hopefully trying to potentiate the immune system with ablation. So I don't know which one would work better, but there's a lot of science out there. Damien Dupuis, has a review article in Nature about ablation and how that can kind of alert the immune system to the presence of the cancer or the presence of not self. And and I think that's an exciting area, particularly when you're talking about the encroachment of Opdivo and Keytruda into the HCC world. It's something that you want to keep on your radar screen. And it's also, I guess for the IRs that would listen to this and they're not in a academic setting, it's something to start talking about with your medical oncologist, because GI ASCO and ASCO are really hot on immunotherapies, and you want to try to position yourself in a way to let them know that you're thinking about it too. And lastly, I would also plug, I was trained that we never biopsy HCC, and we've had a couple hirings here. And we get people out of fellowship, and they say the same thing. And the AASLD would support that. If you have an MRI that shows a hypervascular lesion with washout, and the patient's got an AFP, and they got a cirrhotic liver or a history of Hep C, why would you biopsy that? Well, I actually went to Dave Liu's meeting, the show meeting in Whistler, which I'll plug because I think it's a great meeting, and I have absolutely no affiliation with it. I just like to go skiing and do my thing there. But they, there was a medical oncologist from Canada, which obviously is it's a different system than we have in America. And she discussed, really this concept of each tumor is an individual in a sense. And, we've got these mixed type HCCs. They may be a mixed type cholangio/HCC. And, a cholangio is treated totally differently, at least in my practice, than is an HCC. I mean, a cholangio is going to get gemcitabine cisplatin. We're probably going to do Y90 for it. And so I'm actually pretty big on biopsying. And that's a real change from what I was doing at Georgetown. We would never touch an HCC. We would never ablate an HCC for risk that we would track seed. Now I'm completely the opposite. I biopsy every Y90, at the mapping. I biopsy almost every liver lesion, even if I'm confident it's an HCC, because I think as Terence was alluding to, it's going to be important, and we need to embrace that and be on that front. So, for an endpoint, for me, it's stasis. For Debtaste, it's stasis. I like to see a tumor stain. I like to get a cone beam at the end of a TACE, because I know that in all likelihood, I'm going to try to ablate that lesion. This is a long answer to a short question.
I'm really glad that Justin mentioned that, and I'm really sort of excited to hear that other people out there are biopsying the HCCs, these tumors in general, because we've been running a biopsy clinical trial looking to characterize a variety of different features of HCCs in the setting or before and after TACE, with respect to immune response and metabolic response. And then also looking at some of the genomics of these tumors. And like Justin mentioned, we're finding some really surprising things in terms of what these tumors really are, whether they be mixed tumors or truly cholangios. And I think, there are real limitations to the imaging approaches we're applying towards diagnosing these tumors. And I think we find a lot of surprising things just at baseline about what these tumors truly are. But like Justin mentioned, and as with a lot of the work that's coming out of Sloan Kettering, we're learning a lot about how we can use genetics and even CRISPR-based technology to start to think about generating these precision medicine approaches, which are going to change outcomes. Without a doubt. I think for us, outcomes are a real moving target, just because there is so much heterogeneity in the way that people apply their methodologies, in terms of what they embolize to, or are they applying bland embolics after their DEBs, and that makes it hard for us to draw conclusions from our clinical trials. But I do think that we may begin to be able to stratify some of these responses more effectively using the characterization of these genetic features within the tumors.
Okay. Yeah, I mean, I know I personally have contributed some beautiful biopsies to that trial. So, I guess we should all be thinking. We should all be thinking
the best. I want you to know those are the best ones we have.
Exactly. Our future
How do I
patients
get on this trial?
will be thanking me. So, Terence, you and I actually talked a little bit before this about tumor uptake for HCC and some of those barriers. Could you expound on that a little bit?
Sure. I think there's been a lot of work that already in the literature that talks about the different barriers to therapeutic delivery in cancer. And I think, it sometimes surprises me that we don't have more discussions about this, but I think that they're coming up more and more within IR. And I know that the SIO has been sponsoring fellows and other people to go to a barriers to drug delivery meeting that's run by Rakesh Jain in Boston, who's one of the real pioneers in this field. And I think we have to think about it, compartmentally. There are a variety of different barriers in terms of drug delivery. And as IRs, we overcome probably the most important one, getting a more local regional delivery of our therapeutic to the tumor. But, it doesn't really stop there. I think we really have to think about the other factors that contribute to chemo resistance on the part of the cancer itself, in terms of not just how it reacts to the drug, but how the drug gets to the tumor. So we deliver our embolics into the vasculature, and the drug that we administer has to traverse the endothelium, and get into the tumor itself. And then once it's into the tumor itself, we have to try to make it or create an effect so that it translates through the tumor homogeneously, right? We want every cancer cell to see the same amount of drug. We don't want heterogeneous delivery of that therapeutic. And I think one of the things that will help us get that drug, or the primary thing that will help us get that drug across the endothelium, are the differences in hydrostatic pressure. So we know that tumors are sort of made to mitigate this, but ultimately we need the hydrostatic pressure within the vessel to be higher than it is within the interstitium of the tumor. That will get the drug out of the vessel and into the tumor. But that's really, in my mind, only 25% of the job. We need next to generate or change the interstitial fluid pressure within the tumor so that we favor convection of that drug through the tumor. If there's no difference, if there's high interstatic fluid pressure within the tumor, then that drug is going to get out of the vessel and then basically sit just outside the vessel and not move anywhere within the tumor. So I think we have to think about Starling's equation and how we can modulate that in order to favor drug delivery throughout the tumor.
Okay. And pressure-directed therapy seems to be a way to improve that. What kind of benefits can we get from that in the tumor microenvironment?
So I think that one of the things that certainly pressure-directed therapy will do, and the data for this is starting to come out more and more. It should allow us to increase that hydrostatic pressure within the vessel. So and that will enable a number of things. Number one, it's going to allow us to drive more drug into those vessels, or more therapeutic into those vessels. So we're delivering more of our payload to the vasculature itself. We've also seen how it can induce a reversal of blood flow, so that we're sort of sumping blood away from non-target structures or areas of the liver and towards the tumor. And finally, it should mitigate that hydrostatic pressure gradient I was talking about, where now we are driving those hydrostatic pressures in the tumor vasculature up above the hydrostatic pressures within the interstitium of the tumor, and that should favor translocation of the drug from the vessel into the tumor.
Justin, do you have anything to add about that? And, I know you've got a lot of experience with pressure-directed therapy for HCC.
From a scientific standpoint, I guess, I would be a neophyte in that. But, for me, an anti-reflux catheter was initially, it was really just, I got introduced to it very early because Phil Banovac, who was the chief of the section at Georgetown, happened to be fraternity brothers with Jim Chomas, who's the CEO of Surefire. And, we were doing a lot of Y90 at Georgetown, and he basically said, would you mind trying to use this thing? And, in the beginning, it was all about, the convenience of delivery, and anti-reflux and not coiling the GDA and that type of thing. And the catheter was pretty clunky, and it had a lot of issues with it. But right from the beginning, I have some cases that I shared with Jim where, I would be doing a right lobe treatment, and we would sometimes do it with MAA, just to kind of look at it. And you would see left lobe uptake, and it was odd. And, it wasn't something I was really thinking about at the time, because we were really thinking about, okay, we have this embolic that'll fry your guts out if it goes to the wrong place. So we want to make sure it goes to the right spot. And then, I kind of left Georgetown and left Surefire a little bit, but in that interim, until we re-engaged with it back in Sarasota, there were some, small little studies that looked at, particulate uptake. Specifically, there was a JVIR paper that looked at, MAA end hole versus with an anti-reflux catheter. And they sort of showed that, there was more tumor uptake in that environment where the arterial flow is altered by opening, the cone. And then I had an opportunity to meet with Jim again, and he espoused this this concept of the Surefire being like a spring that kind of pushes your embolic into the tumor, and so we kind of circled back with that, and then Arvind Arapali, who's kind of the developer of the Surefire, he had that paper that looked actually at HCC specifically, and it looked at tumor necrosis and then I think particulate, and they blinded, I believe they blinded the pathologist or something like that. But it was an explant thing where they were taking the HCCs out in a for transplant, and I think they had a degree of necrosis that was increased in the anti-reflux catheter segment of patients. And again, small single institution study, but that kind of turned my attention onto it. And so that's kind of where I am. And, and I think like oftentimes let's say the way that I do Debtaste, you have, smaller beads, and then you have a group of larger beads. Well, at what point do you transition away from your smaller beads? Like when do you go for the larger stuff? And should you just put in the smaller beads so you get to the end and then not put in the larger beads? And, and again, this is a very macroscopic, sort of thought process. But if you can somehow prescribe a dose of a drug, be it 100 milligrams of doxorubicin, 150 milligrams of doxorubicin, whatever you're using, you kind of feel like you want to get that in, right? And so that's kind of where I am on that. And then, when it comes to radioembolization, which is where I really use Surefire, is that one of the problems that I have is that people are looking at radioembolization as and again, this is a little bit of my resin versus glass bias, but it's kind of like, well, more dose is better. And as long as we can get more dose in, it's going to be better. We're going to nuke the tumor, et cetera, et cetera. Well, I mean, as you're seeing in the literature right now, this concept of like a subclinical RALD, not necessarily putting people into liver failure, but, getting that veno-occlusive effect, just like you would if you had a Budd-Chiari, but on a micro scale, that's there. There is radiation injury that happens. And
Absolutely.
So for me, I'm a big dosimetry guy right now. I mean, I've really taken a hard turn towards not prescribing more, but prescribing the right dose. And again, I don't know where that is right now. I'm not sure what the right dose is, but, I kind of, in my own practice, I use the partition method, plus I use BSA. And granted, I'm a resin guy. But I think about it a lot. And if I prescribe a dose, I want to deliver that dose, be it I'm doing a segmentectomy or lobectomy, like I want to be able to deliver that dose. And it's not just, because I want to get lots of beads in there and I want to get lots of radiation in there. It's because I want it to be efficient and I want it to go to the tumor. And so I look at some of those small centered papers and I feel like there's a signal there that, it's going to be difficult to show. It's going to be difficult to show in a big study because there's a lot of heterogeneity, as Terence was talking about, in these different tumors. But I want to be able to deliver that dose. And so I apply Surefire to my practice because I think it helps me to deliver what I want. Be it drug, be it volume of beads, be it activity of Y90. That's my goal. And so, while that's a very, biased, I guess if you want to call it single-centered, opinion, which is really what it is. The one thing that's become true in my practice is, I can balance the cost of the Surefire with the fact that I don't coil people anymore on mappings. I mean, it's very, very rare. And I'm kind of evil about the dose. I mean, it drives me crazy when I go and I just hear like, well, we put 2 vials and, we put 2 vials, 120 gray each. Well, it's like, well, no, you're not. You have absolutely no idea what that absorbed dose is because you're assuming there that there's uniformity in your distribution of beads. And in reality, that we know that doesn't happen. That's a failure of all the dosimetry models. So for radioembolization, if I say, well, okay, I want an activity of 30 millicuries and I want to give it in this specific location, well, I want to get 30 millicuries in, because that's what my formulas told me. That's what the combination of cone beam, volumetrics and all the other stuff told me. And that's, I think if you approach the different treatments, TACE or radioembolization in that manner, you need to have something that helps you overcome those hydrostatic forces. The fact that, a lot of these patients are on VEGF or EGFR inhibition, and that's going to change that microenvironment as well. So if you're not preparing yourself to deal with that, then you're going to fall on your face.
So, Terence, do you think that pressure-directed infusion has the same potential benefits for conventional TACE that it does for Debtaste? What's the difference there that you would get?
So, in my mind, I don't think there's, as I was mentioning, I don't think there should be a huge difference because you're only talking about differences in the delivery vehicle. I think that said, we all know that, some of the problem I think with Lipiodol directed infusion, even if you're using a water and oil emulsion, which is supposed to be focused on drug delivery and not on embolization, which it would be if you had an oil and water emulsion, is that you will get some early stasis. And so, ultimately when I'm administering conventional TACE, I'm focused on trying to generate that water and oil emulsion so that I can deliver the whole dose. So sometimes I'll have to thin that out a little bit just so I can ensure that I'm not reaching stasis before I get to my actual embolics. So I think that ultimately, as I talk through it, in a sense, and I think it's going to be hard to tease these two things apart, but potentially you might get an added benefit from pressure-directed infusion in combination with Debtaste, only because you're gonna be able to, you're going to be able to ensure you're going to deliver that whole dose more easily and not have the complication associated with potential stasis through the Lipiodol. I think, like I said, it's going to be a really hard thing to tease those apart, and I'm not sure it would be significant enough where I would favor one over the other, in the setting of pressure-directed delivery.
Okay, that helps. Well, look, I think we have covered as much of this as we could feasibly get through in a reasonable amount of time, and we could never get through all of TACE and Y90 and pressure-directed infusion, but I think this gives us a great start. Is there anything that either of you would like to add before we sign off?
One of the things I just wanted to just think about for a few seconds is, we talked about bead sizes and how to think about that. Just one of the more basic concepts is, where are we trying to get our therapeutics, and I think ultimately, on average, the size of a capillary in the human body is like somewhere under 10 microns, but the largest capillaries actually exist in the liver, and they can be up to 30 microns in diameter. Which means that in a lot of cases, if you say that the average size of a SIR sphere is 32 microns, maybe, you are functionally delivering these things distally, as much as possible into the tumor, which is where you're going to get your greatest, therapeutic effect from the radiation, obviously. Whereas with embolics and setting up Debtaste or conventional TACE, these things are going to be on the order of 100 microns or greater. And so you're really talking about, at best, administering embolics that get to the arterioles. And so, I think that, in the way we think about, targeting the vasculature, we have to think about how best to achieve the endpoints of embolization. And I think that, as Justin was mentioning, in terms of using smaller particles, we will be able to get these things more distally, and that means we're going to cut off more collaterals and we're going to achieve a greater embolic effect in principle. And I think it's just something we should consider when we start thinking about bead sizes and uniformity of bead size and how that may influence our practice going forward.
Well, Terence, Justin, thank you both for taking the time to share your experience and help all of us battle this challenging disease. And lastly, a big thanks to our sponsor, Surefire Medical. Please visit surefiremedical.com to learn how the Surefire infusion system can help you deliver therapy deeper into tumors while protecting healthy tissues. Thanks, everyone, and join us again next time.
Surefire Medical is proud to support the interventional radiology community in all of its diverse opinions. The opinions in this podcast may not reflect opinions of Surefire.